Thank you so much for joining us this evening. Tonight, we're going to be talking about COVID-19 vaccines, what the emergence of the coronavirus variants means for the effectiveness of these vaccines, and most importantly, what we all really care about, which is the light at the end of the tunnel of this pandemic. I want to first thank the Stavros Niarchos Foundation for their critical support for our education and outreach programming that allows us to host these events. So I'm now thrilled to introduce our wonderful colleague, Dr. Deepta Bhattacharya, an esteemed NYSCF Robertson Investigator alum, expert immunologist, and associate professor of immunobiology and surgery at the University of Arizona. Deepta studies vaccines, antibody responses, and how the body fights off infection using these incredible tools of modern science. A longtime member of our innovator community, Deepta is the perfect person to address all of these questions that we have about the COVID-19 vaccines and what the world may look like this summer. There is so much to discuss. I'm going to jump right into the conversation. So first, right now in the US and Europe, there are 4 vaccines that are primarily in use, with a few others being used in some other places around the world. As everybody knows, I think on this call, there are the mRNA vaccines from Pfizer, BioNTech, and Moderna, the new entry, the J&J vaccine, and the AstraZeneca vaccine, which has been much in the news, which we'll talk about, with the Novavax vaccine seemingly next in line. So Deepta, can you talk about how well these vaccines are working against preventing disease, as well as what kind of a job they're doing at preventing hospitalizations and death?
Yeah, so there's a lot to unpack there. I mean, the first 2 vaccines that were authorized here in the US were both mRNA vaccines. There's the Pfizer BioNTech, and then a week after that was Moderna. And they both reported efficacies of about 95% of preventing any symptomatic disease relative to the unvaccinated placebo cohort, which is pretty remarkable, really. And from my standpoint, that you had these 2 very similar platforms that reached 1% of each other in terms of overall efficacy is pretty remarkable. So what does that mean? That means there's about a 20-fold reduced risk of getting the disease relative to someone who's in the unvaccinated group. So that was remarkable. And I have to admit, I'm on record as of saying this, is that I really did think that we would hit something like this kind of efficacy with those platforms. And, you can follow my Twitter feed and I would have said so. But at the same time, it's really good to see that evidence. Those are sort of the front runners. Those are the ones that are being administered in large quantities here in the US. And as you know, that very recently, the Johnson & Johnson vaccine was also granted emergency use authorization. So that one reported an overall efficacy of about 66% in reducing symptomatic disease. And I want to get into some of that as to whether it's fair to compare those or not. And then there's the AstraZeneca vaccine. And that one, I have to admit, makes my head hurt a little bit in terms of trying to understand exactly what the efficacy is, because there were some differences in the groups. When they received their second shot, whether they received a half dose or a full dose in the first shot. So that one is a little bit harder to unpack. We're pretty sure that it's working. We're not exactly sure how it's working exactly relative to the other vaccines.
So before we delve into the COVID vaccines specifically, can you compare, what does 94, 95% efficacy mean compared to a measles vaccine or a chickenpox vaccine, or other vaccines that we're more used to?
Yeah, a 94, 95% efficacy is right up there with the best vaccines we've ever seen. The measles vaccine, has a reported efficacy of about, I think, 98% or something. But these are all plus or minus within the error bars. And so there's basically as good as the other. The only exception I can think of is like yellow fever, which is the very best vaccine that's ever been made. But by and large, this is right up there with the best vaccines we've ever seen.
So
So
this
that's
is as
outstanding.
good as it gets.
This is as good as it gets. Yeah. I didn't answer, actually, let me go back again. I didn't answer the question about severe disease and hospitalization. So this is a little tricky. The Johnson & Johnson trial was the only one that explicitly looked for prevention of hospitalization as a primary endpoint. And so, the other vaccines, it's pretty clear that it does, but they had so few people get hospitalized even in the placebo group that the overall effect is a little bit hard to quantify. So there, I think what we need to do is sort of rely on what we understand about basic immunology, which is that the hardest thing in the world for a vaccine to do is to prevent all infections. And I think we'll get into that a little bit later. The next hardest thing is preventing any symptomatic disease, and that's what the primary endpoints were designed for. And then it's a little bit easier to prevent severe disease because, namely, at that point, it's spread to your lungs where the antibodies can diffuse a little bit more easily, and the immune system has a little bit more time. And so I think there's every reason to expect that severe disease efficacy is going to be better than the overall efficacy for preventing any symptoms. So if it's 94, 95% at preventing symptomatic disease, I think we can expect that it's going to be better than that for severe disease. But because the trials weren't really powered to look for that, we can't put a precise number on it.
We do have to remember that these trials were done in less than a year, right? So what do we know about how well the vaccines are preventing people from transmitting the virus? That is becoming more and more urgent to understand as more people get vaccinated.
Yeah. So there's two aspects to think about this. And there's two ways in which vaccines can impact and reduce transmission. The first is it can prevent you from getting infected in the first place. And so that's sterilizing immunity, or, for all practical purposes, if it's preventing detectable infections, it's possible that you had one or two cells get infected and it got blown up before there was ever an opportunity to see it. So for me, that's 6 of one or half a dozen of the other. Either way, you're not transmitting. And then the second way in which vaccines can reduce transmission is if you do get a breakthrough infection, what are the viral loads and what is the likelihood that those viral loads are sufficient for you to transmit to someone else? On both of those fronts, things are looking pretty good. And so I think the Moderna trial had the best data for this right at the beginning, and now we're getting more real world data from Pfizer, BioNTech, and some of the others, which is that when you look at the PCR positivity, the people who actually tested positive for COVID overall, irrespective of symptoms, it's down by quite a bit. I think one of the concerns had been that the vaccines might be reducing symptoms, but not actually reducing the infections. I think that was one of the concerns, which I never found very plausible, but it was a theoretical possibility. So what would that mean? So if we're reducing 95% of symptomatic disease, is that then being counterbalanced by a 95% basically increase in asymptomatic disease? That's what it would have to be if there's no impact on infections. But in fact, it's also reducing overall asymptomatic infections as well. So it's sharply reducing the overall number of detectable infections. If you're not infected, you can't transmit. What we're also now starting to see is in people who do get breakthrough infections, that the overall viral load is down by at least 4-fold, somewhere between 4 to 16-fold. And so, it's not much of a stretch to think that that will then, in turn, if you are unfortunate enough to get a breakthrough infection, will be far less likely to transmit to someone else. So by all accounts, the vaccines look good in this regard.
And if you get a breakthrough infection, which is very scary, how likely are you to die or have to be hospitalized?
Well, it hasn't happened yet in the trials. I think that there have been some people a small number of people that they've characterized as having severe disease, but that's based on oxygen saturation. No one in the trials has died from a breakthrough infection yet. When you're talking about so many, hundreds of millions of people, we'll probably hear of some things, but the likelihood of such a thing, I think, is very low.
So I want to just quickly deal with the AstraZeneca vaccine that's been put on pause by a number of countries. Can you tell us what's going on with that?
Yeah, I think this is sort of what we'll call the phase 4 aspect of vaccines, because a lot of times after you run these large phase 3 trials, you still want to see if there's some more rare things that happen, some real world things that weren't fully mimicked within the trials. So there have been some reports of blood clots after the AstraZeneca vaccine. I think if you look at the statistics, it's very unlikely to be related, because at a certain number of people in the population, you will expect to see blood clots at a certain frequency. The question is whether the vaccination is actually driving that frequency up, and there's no evidence for that. And so, from my standpoint, it's been a little frustrating, I think, in this regard, to see it being paused, because I think in every decision in this pandemic, we have to weigh both the costs and the benefits.
Yeah.
And so for every one of these AstraZeneca vaccines that's not going into an arm, there's an increased likelihood that someone will get COVID and die. And so I think these are I think we just have to do a better job of communicating these aspects before we initiate a pause, and I think in turn is probably going to backfire to get people really genuinely worried that this is a real thing, when I really don't think it is.
I agree. There was a similar, opposite, but similar situation with the Pfizer vaccine a month or two ago, where actually it was somebody bled out. It was somebody wasn't able to clot. But again, that's still being investigated. But that was one of many, many, many millions, and it occurs at that same percentage level in the general population.
Yeah, it's one of the things that I try to communicate when I give presentations about how the vaccine trials work, is that you split the people into these different groups, and there's a certain frequency of events that happen. I mean, when you're talking about hundreds of millions of people, in the course of a month, some fraction of them will die, because that's unfortunately that's what happens, right? A certain fraction of people will get heart attacks, but it has nothing to do with the vaccine. So you really need to pay attention to the math and decide, okay, is this likely to have come from the vaccine? Did it happen immediately after the vaccine? Or is this something, honestly, that we're looking at in the general population, particularly when we're talking about, prioritizing people who are older, with health conditions. And, there are things that are going to happen simply by chance, not because of the vaccine.
So I want to just quickly move to where we stand now on vaccinations for children, because in my own family, I have a 14-year-old granddaughter. She'll be 15 in a few months. She's still going to miss that Pfizer cutoff by a year. But we heard today that that Pfizer is close to releasing results on young kids, and Moderna is, and maybe Pfizer too, and J&J are starting with 6-month-olds, through toddlers.
Yeah, I was happy to hear that. I know that both Moderna and Pfizer had initiated some trials in kids, I think from 12 to 16. And until I'd heard today's news, and I actually hadn't known that they'd sort of dropped the age and starting to do some of those trials, which is great. And I know that a lot of pediatric infectious disease physicians have been really pushing for this. It's because, when we're talking about trying to achieve herd immunity and things like that, that's not an easy ask if we're talking about, a good 20% of the population that is not vaccinated.
Right.
We all know that kids are less likely to transmit, but less likely to transmit doesn't mean impossible. And I think that is one of the things that we need to keep in mind. So I was really happy to hear that. So I think that, there are a few things to consider going forward. We're in this is sort of uncharted territory in terms of how do we actually accelerate this process. And so, when we're talking about, vaccinating children, one of the things that I think was of question is, do we need to run a full phase 3 trial again?
Right.
And, at this point, it sounds like they are. And I don't know if that's from guidance from the FDA or that's the way it has to be. What I would really like to be able to get to a point of is, testing vaccines for safety and dosage for sure, in the kids, but then using immunological correlates rather than waiting to see, if they've accumulated enough infections in this group versus that to say, okay, it's efficacious or not. Particularly because as we're heading into the summer, I imagine that the case counts are going to be very low. And so being able to get to the endpoint that we need to be able to say, okay, there's X number of infections in this group, fewer in this group, so we can say it's efficacious. I would so much rather be able to get to an immunological endpoint. And, I know that as we're talking about the variants, I know we'll talk about that later. I know that is what the FDA is saying. Okay, if you have so many antibodies, then that's good enough for us to be able to approve it. And I'd love to be able to see that in kids, but it doesn't seem like that's how the trials are being run.
Well, we have a real world experience in Israel, which I forget the numbers, but it's huge. The percent of the population that they've been able to vaccinate, and they're going right down to the kids.
Yeah.
From my own experience as a grandparent, I don't know. And now there are all these little things. If you're fully vaccinated, go hug your grandchildren. Well, I'm delighted to hold my grandchildren, but does that mean I'm okay hugging my 18-year-old unvaccinated grandchild, my 14-year-old unvaccinated grandchild, the 2-year-old and the 1-year-old? You don't want to transmit, okay, that's low, but you also, it's great that the parents are getting vaccinated. But, I really worry about being able to achieve our goal of this herd immunity without the kids. I don't see how we can do it.
Yeah, I guess we'll see. Like I said, I think that ultimately, a lot of our behavior is going to be driven by community transmission. And so the vaccines are certainly going to help that. And if it drives it down to the point where there's less than one case per 100,000 in the most rosy situation, then I think we can afford to wait a little bit on terms of vaccinating children. But if we don't hit that, then obviously this is something we need to factor in. And I am very glad that Pfizer and Moderna are moving forward on this. I would love to see Novavax and some of the other ones that are a little bit behind push that way too, because I think that could be, the way that they enter into the market. We have a long history of really good protein-based vaccines, and children doing great with them. And so I really would like to see this moving forward. In an ideal world, we won't need it. It'll basically be gone. But the reality is that that's probably not the way it's going.
Well, and as a dad, your kids are how old now?
7 and 9.
Okay, so they're out there mixing with other kids or wishing that they could mix with other kids. Are they back at school?
As of next week, that'll be the first opportunity that we'll have had to be back in person. Yeah.
And I don't know, in your community, are the teachers vaccinated or everybody's just kind of?
The teachers are vaccinated, yeah. So they were prioritized in phase 1B here. And so I think I've read the stats that it's well over 80% of the teachers that have been vaccinated. So I think in that sense, it looks pretty good. And in our schools as well, I'd say about half the children are coming back to school next week. And so then I think spacing and, it's Arizona, and this is a good time to be in Arizona. I think the ventilation, being outdoors, those are all things that are possible.
Right.
Those are things that we thought pretty hard about, but I think at this point, it's been hard on the kids for sure, right? It's been hard for them to be out of school, and TUSD here, they've never had the opportunity since last March to be in person, not even hybrid. And so it's been a year since they've gotten to interact with other children. It's been tough on them.
I think the mental health trauma, the emotional trauma on the world, but particularly on the kids, is enormous, just absolutely enormous. The rates of depression in teenagers and young kids, absolutely soaring. The isolation, just incredibly tough. I know that at one point there's a recommendation that we have summer school. What do you think of that?
Well, I guess it depends where you are geographically. Here in Arizona, it's basically like being in Venus. And so that means being indoors the entire day. So I don't know if I'm down with that here.
Right.
But it makes some sense in other places just to get kids caught up. Again, I can tell you that, my kids are actually in tennis camp this week. It's our spring break here. And just them being able to interact, even though it's outdoors, and masked, and it's not exactly the same. Just being able to interact with other kids, and you can just see the smiles on their faces. So we have to find a way to get this to work.
We do. We absolutely do. Okay, let's talk about the scary variants. I read today that David Ho was saying that in New York we have some, 30 some odd percent of some wacky New York variant that has something in common with the South African variant. There are a lot of these variants. Are they more contagious? Are they more lethal? And honestly, what do we do about it? And do we worry about it or not worry about it?
Well, yeah, no, these are all great questions. So I think one of the best pieces of advice I got from one of my viral evolution colleagues here, Mike Warraby, is that a variant is innocent until proven guilty. And I think one of the things we need to recognize is that this is an RNA virus. It will undergo mutations from the ancestral strains. It just will. And the overwhelming majority of those changes are neutral or detrimental to the virus. They're not things we need to worry about. And I would say up until about November-ish or so of last year, it really just seemed like the genetic diversity of this virus is quite low. And what changes were happening were neutral or inconsequential at best. I think that the major one that started, people started getting worried about was the B117 variant. And I still think that is by far the most problematic one. Because there is really no question at this point that it is more transmissible. And the evidence is really overwhelming for that. Every place it's been introduced, it eventually takes over.
Yes, that's
So
also in New York. It looks as though it's going to take over our own, New York variant.
yeah, so that is the by far the most dangerous one. And now we have probably a good 5-6 different papers that are all through using different methodologies reporting that it is more lethal. And so that is the one that I think is the scariest to me. But the good part about that one is that it's also, we've seen from Israel, fully susceptible to vaccination.
Yes.
And I think that's one of the things that I want to emphasize right now is that, because when you look throughout the world, there are so few people that actually are immune. We're nowhere near the herd immunity threshold right now, much of anywhere. That if a variant is more transmissible, it's not because it's evading the immune system. There's not enough selective pressure for that. Now, for variants like B1351, which was first found in South Africa, it happens to have some changes that affect the immune system in certain ways, but that's not why it's spreading. So anyway, so in that sense, it's good in terms of vaccination because there really hasn't been a lot of selective pressure on these variants to evade immunity or evade vaccination in terms of why it's spreading throughout the population. So B117 is the scariest one, but again, the good thing is that it's susceptible to vaccination.
Can you just explain selective pressure?
Yeah, selective. So we've heard about herd immunity, right? So what is herd immunity? Herd immunity is when enough people are immune that there is sort of a bottleneck on the variants and their ability to find new hosts to infect. And so then community transmission starts to drop. Until you hit that, then what it means though is that there's really not very much reason or pressure on the virus to evade the immune system because it's got plenty of people to infect. Once you actually start getting some immunity within the population, then the selective pressures change from just being able to bounce from one person to another to now necessarily having to evade the immune response to be able to productively infect. So that's what the selective pressure is. And right now, there just isn't enough selective pressure within the population to be driving these variants.
So that's, I guess, the rationale in England for choosing to kind of ignore the trial data, if you will, and get, well, I don't know if ignore is the right word, but to make a decision to get one shot in everybody's arm, and they currently are waiting 3 months for the second shot. That's I think what they're doing, certainly with AstraZeneca. I don't know if that's the only vaccine they're using in the UK.
Yeah, I thought they may have been delaying it for Pfizer too, but I'm not 100% certain of that. Yeah, it's interesting because I think I was very nervous about the strategy at the beginning because so first of all, I want to make a distinction between what happens in like a tissue culture dish, and you're trying to like select for viruses that escape antibodies. You put in just a few antibodies, you allow the virus to mutate, and you see what grows out. That's a lot different dynamic than what's happening in a population level. Because basically, the virus has a chance to mutate when it sticks around in someone for a long time. And so even partial immunity reduces the amount of time that virus can stick around in a host. So that's not really so much the concern. But if there happens to be something that has already evolved, like B1351, like P1 in Brazil, then that has a chance to actually outcompete other variants. So that's one of the things I was a little bit worried about. Second thing I was a little bit worried about was that if you look at the data, both from Moderna and Pfizer, I mean, the levels of antibodies and T cells and things that you see after the first shot are really wimpy. And so I thought, boy, I don't know how much room you have to drop before, you really don't have much protection at all. But what's been one of the interesting things is that now that we have people out in the real world getting vaccinated, those of us at academic centers now have the opportunity to study these responses. And, at least in our hands, the responses after the first shot of Pfizer or Moderna look pretty good. So I don't know what they were doing in the actual trial data, but when we actually test those antibodies on real live virus in our BSL-3 facility, the responses look pretty good. So I am now a lot more open to this strategy that they have in the UK. With all the caveats that it hasn't been tested for it, I think it's likely to be okay.
Yeah, it's interesting. A number of folks have said, you get all your immunity in the first shot, and it's just kind of, secured for duration with the second shot. But I guess we're going to have to see, and that's what they're doing in the UK anyway. So that's going to be a giant experiment.
Yeah. I don't know. Yeah. The people who say that, I'm not sure that that's quite true. So I'm saying that, we see some pretty good responses after that first shot, but a huge amount of variability too. It's almost like natural infection. Natural infection gives you like huge variability in terms of the immune responses. And the first shot sort of gives you that. We have some people, a lot of people have pretty good antibody levels, pretty good T cell levels, but then you have some people who are really bad. You can't see anything. But then after that booster shot, then everything sort of tightens up to a higher level. So I think people aren't wrong in that it does improve the durability of the response. And if you're up here, it's a lot farther to get down to the level where you're not protected anymore. So that's not wrong. But I would also say that the other advantage of getting that booster is it cleans up that variability and gets the set point a little bit higher.
So that leads me to kind of this other area, which is there have been a couple of papers and some suggestion that if you know clinically that you had COVID-19, that you might not need that second shot.
Yeah, and there's a lot of studies now out on this that all basically say the same thing, and I believe it. It's pretty consistent with what we understand about immunology. You form a bunch of memory cells after the natural infection, and if they see something they recognize again, then they go nuts, and then they trigger a new response. I think that probably is true, and we're talking about dose-sparing strategies and things like that to make sure that we get as many people immune as possible, as fast as possible. I think that's a perfectly reasonable direction to go. I don't think our CDC is going to go down that route. But I think that there's been, half dozen to a dozen papers that all say the same thing, and I fully believe it.
So, but I presume there's no downside to getting that second shot.
There's no downside. There's no downside. I think that some of the studies have said that, there's no additional benefit. That's actually not been the case. In our observations, that actually even the people who had previous infections, they get a huge jump after the first shot, and they get actually still a further jump after that from the second. And it puts them probably way in excess of what you actually need to be protected. But I don't think it's actually technically true that there's no benefit to the second shot. So, there's no, if there's no particular guidance from the CDC, then I would say that people might as well go ahead and get those two shots. But it is a conceivable strategy to spare some doses.
So, the other thing that I've heard from people is, well, I'm not going to get the shot because I had COVID, and so I don't need to have a shot at all. And from everything that I understand, that isn't the case. That in fact, the natural immunity that you get from having had COVID is, as you've just said, highly variable, and that also these vaccines can protect against strains that you might not have encountered.
Yeah, so this is sort of a complex topic here. And in some ways, it's a little bit hard to compare natural immunity to vaccine immunity by immunological correlates because, when you got infected, you're getting infected in your nose or in your throat. And so when you look at just the antibodies in your blood after natural infection, and you compare that to the vaccines do better, unequivocally, no question. But what the natural infections also do is they give you some local immunity at the site. And so that's actually in an important way too. So if you sort of just look at the levels of reinfections in people who have recovered from COVID, and you compare that to the breakthrough infection rate in people post-vaccines, it's about the same. And so, what I've sort of been advising people is that there's an advantage to getting a booster shot after you've recovered from COVID. But when we're in a situation where the demand far exceeds the supply, you may want to think about waiting a little bit because there's no question that you're at lower risk than someone who's never seen it in the first place. Once supply exceeds demand or it basically catches up with demand, I would definitely recommend people get at least one shot.
Well, it's interesting. The president said he's going to direct all states to make all adults eligible for vaccines on May 1st. And I think, we can leave for another day all of the different strategies, the varying strategies that different states have have taken. I personally am a huge fan of the Connecticut KISS strategy, which is you just do it by age, and they're going to have even their teenagers vaccinated in May. But do you think there will be enough supply? Let's look at that for a minute for anybody who wants a vaccine to sign up for one in May.
Yeah, I don't know. I think that at the production levels of Pfizer and Moderna right now, well, I think they could use a little help, we'll say. And so then it gets into the questions of J&J. And what I really hope is that they get Novavax online too. And I really hope that the FDA is willing to take the data from other countries because the Novavax trial was run very well. And so, if they're able to get Novavax, we have 100 million doses that we've already purchased from Novavax. And so, if we add up these 4 different vaccines, yeah, I do think so. But it all sort of falls to the FDA deciding whether or not they're willing to take data from other countries and add Novavax to the mix.
Where was
The wild card here.
Sorry. Where was Novavax run? Where were the trials run?
UK. It's primarily run in the UK, but they also have some data from South Africa, which is really useful as well.
Right.
So the Novavax looks great. The wild card here is AstraZeneca. I still am uncertain whether or not it will ever get emergency use authorization here or not. There were some problems with the trials as we talked about. It sounded like we were probably ready to overlook those things because there's been a US run and Mexico run trial. But now even with these somewhat unwarranted worries about blood clots, I'm not sure AstraZeneca will take off here. It may not ever get an EUA, and if it does, I think there's still going to be some hesitancy around it. And so, I've always been an advocate of thinking about this as a global pandemic, and it doesn't make sense for us to hoard 700 million doses. And I really do think that we need to think about some of these underdeveloped countries and making sure that they get their chance too. There's lots of people getting sick and dying in those countries as well. So, is this in a situation where we should think about releasing some of those doses? I think so. We just want to avoid the perception that we're just sort of like giving our leftovers to other countries too. So it's a tricky PR thing, but I really do think we need to be sharing some of the things we have.
Well, I think PR is exactly the right word. I do think that AstraZeneca has had some real challenges just starting right out of the gate with their trial data reporting. And what the reality is, I don't know. We'll see. It seems to be an efficacious vaccine. How long do you think the immunity from both infection and vaccination lasts? And do you think that we're going to be looking at an annual booster in general to give us the duration we need? And are there going to be new vaccines boosters to protect us from the variants? I was listening to a conversation with Stefan Bancel, the head of Moderna. And from a business perspective, he's looking at this as an evergreen business where you just kind of eventually, they're going to layer in the flu and you're just going to get your annual, maybe it's like a pan-corona flu vaccine. But how long, those of us who've gotten our shots or eagerly waiting those appointments or hoping they'll get an appointment soon, how long do you think the immunity is going to last? Let's start with that one.
Yeah, so there's 2 factors that control how long you're immune for. One is how long do the immune cells and the antibodies persist? And then the second is, does the virus change or adapt to evade what's already there? So I'll answer that first part first. So after infection, I mean, we and many other groups have followed this out for 8-9 months, and the frequency of reinfection is very low, and the antibodies, as far as we can tell, seem to be maintained reasonably well. Will that last for another year, another 10 years, another 20 years? I mean, we don't know that. But as far as we've been able to,
we're talking infection.
From infection, that's right, from infection.
Okay.
From vaccination, we don't have a lot of long-term data. I mean, these are the first times that we've really seen, mRNA vaccines roll out. Moderna has published some data in the New England Journal showing data out to about 4 months. And so that looked actually really good to me. So when we back up a little bit to the natural infections, and we talked about this, is that the level of immunity and antibodies is extremely variable. And yet when you look across this population, the frequency of reinfections is very low. It's not zero, but it's very low. So that to me from the outset basically said that it doesn't take very much to protect. So that's a very good thing because, after that second shot of Moderna or Pfizer, you're so far above what we think is the protective level that I think it's going to take a long time to get down below to the level where you would no longer be protected because the antibodies or other immune cells faded out. Okay, so that's a good thing. The other issue now are variants, and I think that's where it's a lot more difficult to see how things play out. Is this going to be something that ends up being more like polio or measles, where you can basically drive the endemicity down to very low levels where it's less of an issue? Or is it going to be something more like the flu, as you said, where we're probably looking at annual vaccinations? And, what I would say is that there's lots of predictions. But I think that anyone who boldly asserts that they know exactly how this is going to go is probably someone you shouldn't be listening to. So what are we looking at right now? In terms of the current variants, I think the ones that are most concerning in terms of immune escape are B.1.351, which was first found in South Africa, and P1, which is in Brazil. And again, I don't think that they're spreading right now because they're evading the immune system, but they clearly have some associated mutations that do affect antibody binding. For most people, I don't think that's all of a sudden going to lead you down to zero protection, where you're just as likely to land in the hospital if you see one of those as if you had never been vaccinated or infected in the first place. So I don't think we're there yet. But could it be the beginnings of a problematic lineage that then does more substantially affect vaccine immunity or infection-induced immunity? It could. So then the question becomes, how much room and tolerance does the virus have to accommodate genetic mutations? And then you sort of calculate in how quickly is the virus mutating. And there's just almost an infinite realm of possibilities. And so it's very difficult to predict how this will go. If I had to bet, I'd say that we can probably count on a couple of more boosters against variants. And then what I'm hoping is at that point, we're looking at probably pretty low endemicity. That would be my best guess, but there's just so much uncertainty around those predictions.
And before we leave the question of the specific vaccines, it's exciting to have a one and done with J&J, but, should people feel, well, they really, the better vaccines are the mRNA vaccines. The messaging is just get what you can get.
Yeah, and I've been a little bit uncomfortable with that messaging, Susan, to be honest, because when, particularly when we're really, one of the things that we need to make sure of is that we're getting these out to communities that have been hit especially hard. Here in Arizona, it's a Native American population. We know Black and Hispanic communities have been just absolutely hammered by the virus. And I think that honest and open communication is really important as we try to get some of these vaccines out to these communities. And when you see a headline of saying, 94, 95% efficacy, and then J&J reporting 66% efficacy, and then those of us out here insisting that they're the same, that sort of breeds a certain degree of mistrust. So I don't want to go there. But here's what I would say, right? I mean, the choice before us at this point is vaccine or no vaccine. I mean, and so if vaccine is J&J, that's an awful lot better than no vaccine. And what I can also tell you is just sort of anecdotal, but in some of our own studies, we've seen people that have gotten the J&J vaccine and then the first shot of Moderna, and their antibodies go absolutely through the roof. So I want to make clear that this is not a lifelong commitment. It's not a marriage, right? If you get the J&J vaccine, you're not stuck with that forever.
Right.
It's that this is what buys you some time and some protection. It may be good enough. And if community transmission comes down by us all doing our part and getting vaccinated, then maybe the next booster is unnecessary. But if you need it, you can get it. And I'm sure we're going to start to seeing some experimental data that proves that.
Yeah. So in other words, you're not probably, certainly when it comes to the booster stage, we're going to be looking at a mix and match. I mean, right now, you don't ask what brand your vaccine is when you go get your vaccination for whatever it is. You get what you get.
Right.
Well, that would really be ideal. So do you think that we're going to see another surge, crystal ball time, in the fall or winter?
No, I don't. I don't.
Yes.
And so, there's a few reasons for this. I mean, I think this gets into the weeds of the coronavirus biology here, but what I've been pleasantly surprised by, as I said before, is that it doesn't seem like it takes much to protect. So that's a good thing. There's also a whole bunch of different places on the famed spike protein of the coronavirus where if an antibody binds, it prevents infection or limits infection.
Right.
And so, the coronavirus biology isn't like the flu, where you have this segmented genome where it can swap parts out with other viruses that happen to be in the same cell. That's by and large not how this coronavirus works. And so essentially what it has to do is sequentially mutate each of these things to get out of the way of antibodies. And so, where we really ran into trouble here is that there were so many worldwide infections that there were so many possibilities that something basically managed to get selected out. There's a nice article in the New York Times that explains how probably B117 emerged in probably an immune compromised individual. So you can have these rare events that take off. But if we get a lot of people vaccinated, a lot of people already with natural immunity, then those case counts are going to drop and there's fewer opportunities for these rare jackpot mutations to emerge and the virus to start escaping out. So fall, winter, my best guess, no. 3-4 years from now, might we need some boosters? Maybe, in terms of having something that's really problematic. So that's my best guess. It's entirely possible I'm wrong and we'll need boosters a little bit more frequently than that before we get it to low endemicity. But I'm not thinking that we're going to have gigantic surges in the fall and winter again.
So I can't resist. There was some recently. There was just a little noise about having vaccines that instead of being a shot or a nasal vaccine, and how that might be better because you're actually delivering it where the reservoirs are.
Yeah, I mean, it makes a lot of anatomical sense. Basically, the anatomy of the upper respiratory tract is that there's a sort of a tight epithelial barrier, and on the other side, there's some mucus that is basically designed to slow things down and keep it from getting into you. But the flip side of that is it's also a little bit hard for things like antibodies to get out. And so there are specialized types of antibodies that are generated preferentially when you get an intranasal or an oral vaccine. And so I think the thinking is that, those might be a little bit more effective at blocking infections outright. Even though actually these vaccines that we have right now seem to be doing a pretty good job of that. So I'm fully in favor of developing those kinds of immunizations. I do think that there's been a little bit too much put into arguing that an intramuscular vaccine can't possibly prevent infections because now we know that's not true. It just isn't. And at the same time, assuming that because you have an intranasal vaccine, it's a panacea. What we know really, the most data from the flu vaccine where you can either get an intramuscular vaccine, that's the quadrivalent inactivated vaccine, or you can get the live attenuated vaccine in your nose. And, so what I'd say is that the data on that side is a little bit confusing. There's some good data that in children, the intranasal vaccine works better. And there's some equally good data that in adults that it works worse. And the reasons for that are complicated. We don't fully understand. So I would say that we need to keep all possibilities open. We should be pursuing that. It makes a lot of immunological sense, but I think the vaccines we have right now are pretty good too.
So are we in a new golden age of vaccines? I mean, it's very
Boy, I hope so. That would be good for business for me, for sure. I think that we've really long neglected infectious disease as a driver of human suffering. I mean, I think in large part because the more developed countries, it's not as much of a burden as other types of diseases. But it's still the leading killer in underdeveloped countries, and I think we've long ignored that. I really hope it does bring new attention to vaccine development and paying more attention to newly emerging pathogens and other things that we really need to be sort of getting a handle on and dealing with rapidly. I'd love to have a system or a pipeline in place where we can take vaccines against respiratory infections and other possible flaviviruses, other more problematic things, to at least the phase 1 level and have them almost ready to go should something emerge in the future.
Well, I think that's the mRNA dream, right? And also to
Absolutely.
have better flu vaccines so that we're not, culturing in an egg and, trying to figure out what happened in Australia and, how it's going to convert to this country. So the other thing that people worry about, people are concerned either they're going to have a really strong reaction and they're going to feel miserable, but then those people who don't feel miserable and are just kind of like fine, maybe their arm is a little sore, whatever, they worry that they're not having an immune response that will protect them.
Yeah, the party line here, Susan, is that it won't matter. But the question is, do we really know that?
Yeah.
And so we're actually doing some of those studies right now. We basically got questionnaires. We have a huge antibody study that we're running out of the University of Arizona, where we've added some of those questions because I want to see. I mean, so if you look at the trial data, some 75% of people will have some sort of reaction, and presumably 25% ish or so don't. And the trial data doesn't really sort of disaggregate the results, based upon that. But the question is it exactly the same? Is someone who has fewer symptoms or someone who takes a painkiller, are they a little bit less? And frankly, we don't know the answer to that. I really doubt that it's going to be a dramatic difference. But I can tell you within our own household, it was the same. It was sort of, we have a test example. So my wife and I are going to have basically a head-to-head competition because I ran about 102 fever the day after my second shot, and it wasn't terrible, but I didn't feel great. My wife had nothing. And so we are bleeding ourselves, and I'm going to run those tests myself in our BSL-3 facility, and we'll let you know how it turns out.
I think it's great. I think my husband and I would sign up for the same thing because we were just the same way. I was down for the count and he was like, what? So interesting. And you think the antibody tests that you're running, you do levels, not just positive or negative?
Our clinical tests are just positive or negative, and that has a lot to do with FDA and sort of clinical considerations. But what I bring back in my lab, I can certainly, and I can't report that back to people who take our antibody test, but I will certainly know that.
That's good. So some real world questions here, and we actually are incorporating people's questions as we go along. What can people do when they have been vaccinated? So I'll give you just a few examples. So let's say people in their 70s have been basically told by the CDC that they can be with their unvaccinated grandchildren, assuming that the unvaccinated grandchildren are not in some kind of in a high risk category because of other comorbidities. So there's that. Then there's, can I go get a haircut? Does it have to be outside? Can I give a hug to my grandchild? It's really I'm going to put to the side that vaccinated people can be with vaccinated people, can eat together inside. I don't know about giving each other hugs. You might want to comment on that. But what about vaccinated adults, unvaccinated kids, and teenagers?
Yeah. And so, Susan, I'm going to diverge a little bit from how public health messages in this case. I mean, I sort of side more towards on the physician side, where I really think the best thing to do is to inform people of the relative risks so that they can best manage those decisions rather than saying, yes, you should absolutely do this, or no, you should not, to explain that, obviously anything that's outdoors is going to be at lower risk, right? So, If you have to get together with other people, outdoors is lower risk. The counterfactual to outdoor risk is basically people then going inside. I think this is one of the things we've learned is that you can try to tell people to stop doing everything, but ultimately what you end up doing is just driving some of those behaviors underground. So I think it's really better to say, this is a safer activity than this is a safer activity than this, and sort of use people's best judgment to guide that. So what do the vaccines do? Again, I'll go back to the clinical trials. We know that there's about a 20-fold level reduced risk. You're 20 times less likely to get symptomatically infected if you have had the vaccine. That's not accounting for the variants, but I think it's a general guideline, right? You're also roughly that much less likely to transmit to someone else.
20%?
20-fold, not 20%, 20
20-fold.
times, right? But at the same time, it's also important to know that when community transmission is high, and in some places they still are, you will hear of people getting breakthrough infections. You will hear of people who have been vaccinated that then transmit to others. So I think these are the factors that I'd rather sort of communicate to people. These are the relative risks and odds, rather than saying, yes, you can do this activity. No, you can't do this one. Rather just explain the relative risks of those activities.
That's kind of tough. There you are, you've got maybe, you have unvaccinated, babies, children, teenagers. You've got maybe a vaccinated adult child and an unvaccinated adult child. You start out with masks, it's cold, people go inside. You've got kind of the real world there. And then, it's difficult.
Yeah, and I think that's, again, why I really, want to arm people with the agency and the information to make some of those decisions. I just feel like when you're absolutist about what people cannot do, then it just drives those behaviors underground. So I think it's really most important to basically say, these are the circumstances in which this is the risk. And again, if we get community transmission down to where it's 1 in 100,000, case counts, then that obviously, again, further changes it. Likelihood of getting infected or transmitting to someone else after you've been vaccinated is extremely low under those circumstances.
Now, what do you think the role is of rapid, inexpensive tests? Our colleague Feng Zhang and others have been trying to, have like a nickel test that kind of works like a pregnancy test or a blood glucose test that you have really quickly. I know there's the Abbott and others have some tests. How are we going to be in a situation where we incorporate that kind of testing into the mix as well?
I would love to have seen that already, to be honest, Susan. It's been one of the great frustrations that we haven't. And we do use it here on campus, actually. When we test all of our dorm students, we use rapid antigen tests. But it's been extremely frustrating to get our way through the regulatory process of those. There is no regulatory process in place for public health surveillance. Everything that comes onto the market all has to meet clinical standards, and then the clinical standard right now is PCR. And so then if the antigen tests are substantially less sensitive than the PCR, then it basically doesn't meet the standards you need to get FDA approval. So that's been extremely frustrating. I think that as we lick our wounds a little bit this summer and think about what are some of the things we could have done differently in the pandemic, having a regulatory infrastructure for public health surveillance has got to be super high on the list. So it's a roundabout way of saying that I'd love to see that, but we're really handcuffed in terms of how we're allowed to use these tests.
They exist. It's just
they absolutely exist.
They absolutely exist. But it's just all of the regulations are don't use them. Unless
and even the
reason for that.
Yeah, and even the FDA is sort of like a wink wink. It's like, well, if you get a positive test, then you can maybe refer them to a clinical test. But so they're basically trying to map out loopholes to their own regulations, and it's been tough to get past that. So I really hope that we think about a better way to get such tests onto the market, because they could have made a huge difference.
Yeah, I think so. What test is Arizona using? Or did you make
We're using the Quidel antigen test. But again, this is one of these things where we've had to, because we're using it on site and not in the CLIA lab itself for some of these things, we've had to get a doctor's order to basically have a standing way to be able to test,
They
and
have like
doing
a
testing.
standing doctor's order for how many thousands of students?
Yeah. I mean, it's these silly regulatory loopholes, and we all know what we're doing. I'd rather just be able to do it on the up and up.
Yeah. How quickly does the Quidel return results?
I think you can get it in 15 minutes or something like that.
Is
It's
it
pretty
nasal
fast.
swab or saliva?
It's a nasal swab, but it's not the deep nasopharyngeal swab where they stick it up to your brain. It's just mid-terminal. I've done it myself. It's no big deal.
Yeah, it's so great. So I continue to get questions here about the J&J vaccine and how quickly is it does it provide immunity as
2
compared
weeks.
to
2
2 weeks?
weeks. Yeah.
Okay. So it's the 2 weeks. So it's not
Yep.
different than the mRNA.
It's not really, but again, because it's one shot, you kind of get there a little bit quicker, probably.
Right. Okay.
Yeah.
Well, that's actually a really good point.
Yeah.
So I'm just going to ask my colleague here, David McCune, to jump on and see if we have any other questions before we wind things down here.
Well, there's a hey Deepta, there's a couple questions about the further about the J&J, and there's some talk about increased immunity over time with the J&J, and also what it means in terms of the variants, the reduced efficacy versus the Moderna and the Pfizer BioNTech, and what that means for the variants.
Yeah. So the J&J is an interesting vaccine because, and I just told Susan that that's 2 weeks where you start to see, decent immune responses. But if you look at the phase 1 data, the antibody levels keep climbing. So at 14 days, it's something, 28 days, it's a little higher, 71 days, it's even higher than that. And so it does make me wonder, we have the 66% efficacy number, but that's measuring it out from 14 or 28 days post immunization. But if you looked at it post day 71, I bet you it'd be higher. So that's point one. Second thing around the J&J, and this is interesting too, and I'm still trying to get my mind around this, which is that they actually did test for efficacy against the B.1.351 or efficacy in South Africa, where the B.1.351 mutant is predominant, and it doesn't take very much of a hit. So if you look at the efficacy here in the US, it was 72%. And I think it was 64% or something against that South Africa variant. So that's outstanding because it means it doesn't take much of a hit. So that's great. And I think in many ways that would have been my expectation, given that it doesn't seem like you need a ton of antibodies or T cells to protect against the virus. That's great. The Novavax one is a little bit interesting because that took a much bigger hit against South Africa's predominant variant. And I don't exactly understand why, because the antibody levels from the Novavax vaccine were great. So that fell from like 96% against, I don't know what you want to call it, COVID classic, versus, down to about, 55% against the B.1.351. So that was a little bit surprising to me. So in that sense, the J&J vaccine actually is performing pretty well against the variants that we know about.
Well, I think this has been a really great and extremely comprehensive chat. I know this subject is going to be with us for a while. I'm really eager to hear more about the kids as we kind of move into the summer. I pray to God that people continue to keep their masks on, continue to be socially distant. It's really a drag. But as Francis Collins said, you just don't want to be that person who's just within a few yards of making the goal here. So anyway, Deepta, thank you so much. Really deeply appreciate your time with us and all that you're doing to help keep us safe.
Thank you so much, Susan. It's always a pleasure. I'm happy to be on whenever you want me.
Well, we're going to take you up on it.
Okay.
Thanks a lot. Be well.
Bye.
Thank you, everyone.